In the following, I want to answer two questions. Which types of cancer have the most promising characteristics for mRNA vaccine development? Are there any cancers where developing an effective mRNA vaccine is difficult or impossible due to biological or immune system limitations? The most important tumor-related factors for the effectiveness of mRNA-based vaccines include the degree of immune suppression within the tumor microenvironment, the mutational burden, the mutation rate of tumors, and the expression of MHC molecules, which directly influences antigen presentation to immune cells. The effectiveness of mRNA-based cancer vaccines is greatly impacted by the immunosuppressive tumor microenvironment. Key factors include regulatory T cells and M2 macrophages, which suppress immune responses and promote tumor growth. Hypoxia and nutrient deprivation further weaken immune cells. Immune checkpoints also inhibit T cell activation, limiting the vaccine's effectiveness. Additionally, immune cell infiltration into tumors is crucial for vaccine success. In suppressive tumor microenvironments, infiltration is restricted, reducing the anti-tumor response. mRNA vaccines work best in tumors with a less suppressive tumor microenvironment, while combination therapies may be needed in more resistant tumors. The highly immunosuppressive tumor microenvironment of pancreatic carcinomas, glioblastomas, and classic Hodgkin lymphomas presents a major challenge for CD8 plus T cell infiltration, necessitating targeted combination strategies. In contrast, bladder, head and neck, kidney, and liver cancers, as well as melanomas and non-small cell lung cancer, have a weaker immunosuppressive tumor microenvironment with a naturally high immune cell infiltration rate. These tumors elicit a strong immune response even without immunotherapeutic intervention and are particularly responsive to immune checkpoint inhibitors. Given this context, the use of mRNA-based vaccines appears to be especially promising. Tumors with a high mutational burden present a high diversity of neoantigens and are more easily targeted by the immune system due to stronger dendritic cell-mediated antigen presentation and a higher number of immunized T cell populations. Tumors with a high mutational burden include some lung cancers, melanomas, bladder cancers, and certain colorectal or skin. The facilitated identification and selection of particularly immunogenic neoantigens promote the development of personalized therapeutic approaches in tumors with high mutational burden, such as mRNA vaccines. A high mutation rate due to chromosomal aberrations, DNA polymerase mutations, or defects in DNA repair mechanisms leads to a high mutational burden, as well as heterogeneity and therapeutic adaptability. Particularly in tumors with changes in chromosome number, chromosomal rearrangements simultaneously affect multiple genes and are more likely to result in multidrug resistance. Additionally, the efficacy of personalized therapies, such as mRNA vaccines, is limited by mutation-induced changes in neoantigen expression. Particularly high mutation rates are found in melanomas, non-small cell lung cancers, gastrointestinal cancers with high microsatellite instability, and urothelial cancers. In contrast, low mutation rates and consequently better therapeutic outcomes are observed in pancreatic cancers, prostate cancer, gliomas, and sarcomas. The expression of MHC1 and 2 molecules is tissue-dependent, and their tissue-specific regulation serves to recognize foreign antigens in exposed tissues or protect against autoreactive immune cells. Genetic defects, such as those in beta-2 microglobulin, epigenetic silencing mechanisms, or post-transcriptional regulation, can lead to reduced MHC1 expression in tumor cells, correlating with poor immune recognition by CD8 plus T cells and a weak immune therapy response. In this context, immune cells, lymph nodes, and the spleen, as well as melanomas, Hodgkin lymphomas, and certain types of non-small cell lung cancers, exhibit high MHC1 expression. High MHC2 expression is found not only in dendritic cells but also in melanomas and subtypes of lymphomas. Particularly low MHC1 expression is observed in breast cancer, colorectal cancer, prostate cancer, and some lung cancers. These findings highlight the complexity of tumor-immune interactions and the need for tailored immunotherapeutic approaches, especially when considering mRNA vaccine development. While promising progress has been made, ongoing research is essential to optimize vaccine strategies, improve patient outcomes, and overcome the challenges posed by highly immunosuppressive tumors.